Thank you for this opportunity. I'm Pamela Duncan, and I'm a professor of neurology at Wake Forest Baptist Health, and I'm also the founder of Care Directions, a new startup to be able to move patient assessments of functional and social determinants of health right in the middle of healthcare and to develop actionable care plans based on the patient's perspective. Right. So we have been on a journey for the last 8 or 9 years, funded by the Patient-Centered Outcomes Research Institute, to be able to engage patients and their care partners to manage their health after stroke better. And so we've had funding to do this, and in the midst of this funding, we've developed the technology in real-time clinical practice with frontline clinicians to quickly access their social and functional determinants, take that information and turn it into an individualized care plan for their comprehensive recovery or for specific blood pressure management. So our major challenges in healthcare is that we do not tailor our interventions for our diverse population. And the diverse population is not only social factors, but it's also their functional status. So what we do is, and rather than sending a patient and their blood pressure is out of control and, oh, we better start managing their blood pressure, we make the clinician and the patient aware about what are the factors that influence your ability to take your medications. Can you afford your medications? Do you understand why you're taking your medications? So we tailor it for the social and functional determinants. Now, what is different about what we do, we don't just take the information and, right. So basically one of the barriers we found in implementation, it's really the payers. Whereas the Center for Medicare and Medicaid has put forth different reimbursement codes to manage the patients within the context of their social and functional determinants of health and follow them up immediately after stroke or congestive heart failure. They put those funding codes, but guess what? There's a pretty big copay on that service for patients who are socioeconomically disadvantaged. So what we have to do is we have to pivot to the payers in a different way. So we go to get health systems to do it, but really the burden of this care is on the payer system. The management of complex chronic conditions is a $50 billion industry a year of lost resource, poor management, and poor patient satisfaction. So we have to engage with the payers, and payers say they have programs, but you know what they're doing? They're calling me up as a daughter of a man in congestive heart failure and saying, oh, by the way, this patient needs to get to the doctor. Did you get the dental appointment? Did you get the medication? And they're expecting me as a daughter 150 miles away now. And as a daughter, I'm saying, excuse me, this man needs to be able to get up and move, right? But you're not providing the services for them to do it. So what we've done is that care is it's the patient, and it's the care partner, and it's the community in which they live, right? So what we have to do, we have been highly successful, as presented by Dr. Blood yesterday from Harvard and Mass General in cardiovascular management. What Mitch Eflin is doing at Columbia and what we're doing is that this works. We can lower blood pressure, but it takes a multidisciplinary approach, but we've got to make it efficient and effective. We can't have 1,000 clinicians sitting in the team. So what our platform does is know when to deploy the right team, and it's managed by a nurse practitioner or a nurse. It's a nurse-supported intervention. We don't have enough cardiologists, we don't have enough stroke doctors to manage it. So it's a nurse fund. But the other issue is, well, do you even know what resources are available in your community? For example, United Healthcare, Blue Cross Blue Shield offers silver sneakers in the community. That's a program to get you physically active. Well, most of our major cardiovascular frail patients and stroke patients can't participate in that, so they think they've done their job. But there are other programs in the community, like the Area Agency on the Aging program. We know what those are. They're more tailored for the frail, the more chronically disabled. So we have to quit abandoning the patient, and we have to link them to those community-based resources.